Thank you for joining us today for our second Hopkins at Home live stream, co-hosted by the Johns Hopkins India Institute. My name is Alex Triantis, and I'm the Dean of the Johns Hopkins Carey Business School. While the Carey Business School is about 15 years old, Johns Hopkins has been teaching business for over 100 years, roughly as long as Johns Hopkins researchers have been working with Indian institutions, first with the All India Institute of Hygiene and Public Health in the 1930s. The Carey Business School has embraced the Hopkins tradition of excellence in science, research, and health by focusing on becoming the premier business school in the field of health. Our commitment to health also aligns with our unwavering commitment to humanity, one of our school's core values. Our faculty and students are focused on how to make healthcare more accessible and affordable around the world. They are doing so working alongside physicians, public health experts, and policymakers across Johns Hopkins, tackling healthcare challenges through cross-disciplinary initiatives. The opportunities to make an impact on society are enormous. Healthcare represents a fifth of the US economy, and healthcare expenditures account for nearly a tenth of global GDP. Producing leaders in this field is critical, and we have many programs designed with this in mind. For example, half of the students in our newly redesigned full-time MBA program are focused on health technology and innovation. More than 35% of our working professional students in our flexible MBA program are concentrating on healthcare management. And we are also one of the few business schools to offer a master's in healthcare management. We also offer executive education programs in healthcare management, including our Academy for Healthcare Leadership and Management, and new programs are being developed on behavioral economics issues in healthcare and the business of healthcare security. We are proud of all these innovative programs and are currently in active discussions with leading business institutes in India about partnerships to offer some of these programs in India as well. The Carey Business School has educated many alumni having an important impact in the health industry. For instance, Bill Enright is the CEO of Vaccitech. His company has developed a leading COVID-19 vaccine together with Oxford University, which is being licensed by AstraZeneca. And Dr. Redonda Miller is the president of Johns Hopkins Hospital, one of the most successful and renowned hospitals in the world. More than a quarter of our business faculty members are involved in innovative research in the area of business of health, including Professor Kathleen Sutcliffe, a Bloomberg Distinguished Professor, who has reimagined the way we think about organizational resilience in healthcare, a critical issue during the recent pandemic. My distinguished finance colleague, Professor Prabhala, the Francis Carey Professor of Finance, is investigating how direct subsidies affect health and developmental outcomes at a household level. Professor Daniel Polsky, a prominent health economist cross-appointed with the Bloomberg School of Public Health, is the sole economist serving on a panel of experts recently formed by the National Academy of Medicine to provide recommendations to US policymakers on the equitable allocation of COVID-19 vaccines. Professor Polsky is also leading the Hopkins Business of Health Initiative, which is a collaboration between the Carey Business School, the Bloomberg School of Public Health, and the Johns Hopkins Schools of Medicine and Nursing. This initiative is integrating research, practice, and policy across Johns Hopkins to improve the productivity of the nation's health system. Given all these interests and accomplishments of our faculty, alumni, and students, I am thrilled that the Carey Business School is part of the Johns Hopkins India Institute. Like Carey, the Institute is bringing together the best of Hopkins, in this case for the sake of serving and partnering with one of the world's most populous and influential countries. And you need look no further than our guest speaker, Bloomberg School of Public Health alumnus, Dr. Indu Bhushan, to see how India and Johns Hopkins are making a difference. With us today is Dr. David Peters, Edgar Berman Professor and Chair of the International Health and Director of the Alliance for a Healthier World at the Bloomberg School of Public Health. David, thank you for leading today's discussion, and I will pass it on to you now to give you the honor of introducing Dr. Bhushan.
Thank you, Dean Triantis, for your very kind introductions. Today we're going to be talking about India's digital health mission, which is one of the most ambitious digital health initiatives anywhere in the world. And we're lucky to be talking to somebody who's responsible for its implementation. What's even more impressive is that the same person is also leading the rollout of one of the largest health reform interventions anywhere in the world, the Ayushman Bharat PMJ health insurance scheme. Taking both of these on and doing both in the midst of a pandemic makes it truly incredible. So I'm really delighted today to speak with my old friend Indu Bhushan. Maybe I should say longtime friend rather than old. But let me tell the audience a bit about you. He was trained originally as an electrical engineer, and then Indu became an Indian Administrative Service Officer before coming to Hopkins to pursue further studies in a master's and doctoral degree where he focused really on health economics. And he did them both at Johns Hopkins at the Bloomberg School. After graduation, he worked as an economist at the World Bank before moving to the Asian Development Bank. At the ADB, he worked as an economist in a number of social sectors and then took on several leadership positions, from being director of the Pacific Department to director general of strategy and policy department, and then director general of the East Asia Department. And then at that point, he was finally enticed to come back to India to take on these major challenges. Just to say, I was fortunate enough to both be a student with Indu at Hopkins, then to also work with him at the World Bank. So I understand firsthand how his vision, his drive, and his collegiality have really helped him to make him so successful throughout his career. Right now, Indu is the Chief Executive Officer of the National Health Authority. Its first mandate was the implementation of the Ayushman Bharat PMJ program, and then more recently taking on the implementation of the National Digital Health Mission. For those of you who may not know, the PMJ is the largest government-funded health insurance program in the world. It's now recently its second anniversary, and its scheme provides cashless insurance to secondary and tertiary care for more than 500 million or 50 crores of India's poorest citizens. The NHA, as a CEO, is also charged with implementing the NDHM, which has a massive vision, really, of creating a national digital health ecosystem to support universal health coverage and providing this wide range of data information services to a wide range of customers and purposes. Now, you have many accomplishments and awards, and I could probably spend most of the hour talking about them, but I think it's better that we hear from you directly. So I'm going to be, I'll ask you some questions. Just want the audience to know that we'll also be taking questions in the chat box. So please feel free to use the chat box and add questions. So Indu, thank you very much for being with us today. And let me start off with asking you about starting off with the NDHM. Can you tell us why the NDHM came to be and why now?
Thank you very much, Peter. Thank you very much for a very generous, probably undeserved introduction. And thank you very much for having me in this session. Always great to connect with Hopkins and get back to my roots. Now, coming to your question about NDHM, why now and how it came to be. As maybe some of you may know, that our Prime Minister launched it 2 months ago at the time of our Independence Day, which is 15th of August. And so we've been implementing it for the last 2 months. So you're right, I'm looking after two schemes right now. One is the National Digital Health Mission. Other one is the Ayushman Bharat PMJ. PMJ actually has completed 2 years. And NDHM has completed 2 months. So one is 2 months old, one is 2 years old, and none of them have matured yet. And NDHM, of course, has a long history, and some would say that it should have been in place much longer. And given the fact that India has such a strong digital and IT strength, it is ironic that India is coming to the party so late, but never late than never is better than late than never. And so the whole process actually has started a long time ago. And we were talking about a mission like this in 2010 as well. But we have a national health policy which came into place in 2017, which actually identifies the need for a digital health platform where we can provide better information and connection between people and their health conditions, and I'll explain that later on, David. And then based on that, there was a group formed which created what we call National Digital Health Blueprint, which was released in 2019, and it was languishing for some time. And COVID gave an impetus, and one of the reforms government put in place in the health sector was to make this mission a reality. And it was launched like I was saying, 2 months ago. And we were given about a couple of months to prepare for it and be ready for launching it. Actually, slightly less than 6 months I got for implementing and launching PMJ, because I was told to get ready on 1st of May that we are going to be launching this PMJ on 15th of August again. And luckily, it was delayed to 23rd of September for various reasons, but still, I got 6 months for preparing for PMJ and 2 months for preparing for National Digital Health Mission.
Thanks. That's very impressive. So a long build up, and then suddenly have to go into high gear. Maybe could you tell us a bit more about, in the long build up, who was consulted in the framing of this program? Because I think that's going to be key to how it's implemented as well.
Well, in preparing the blueprint, large number of people were consulted at various times. So as you can see, there are a huge number of stakeholders here. Of course, individual and citizens being primary stakeholders, but then we have medical professionals, we have hospitals, other health facilities like labs, diagnostic centers, then private sector, a lot of insurance companies, a lot of pharmaceutical companies. And so even for preparing for implementation, we had consultations with the huge number of these stakeholders. I think, and also right now we are in the process of finalizing our data security and privacy policy, which was put on the website for consultations. We've received more than 7,000 inputs on that policy that we are trying to now go through and reflect. So in terms of consultations, both within the government and outside the government, large number of people were consulted. And I think it's both a challenge, but also a source of gratification that there's so much interest in the mission and what it seeks to achieve.
That's great. Very impressive to hear. Now, the NDHM blueprint has this principle about think big, start small, scale fast. We're hearing a bit about the fast, but can you tell us a bit about what this means in practical terms? This think big, start small, scale fast. Maybe with where you're starting now.
Well, David, if you look at the whole concept of National Digital Health Blueprint or mission, the whole concept is very comprehensive, very ambitious, huge in a way. Think of providing health ID to more than 1 billion people, giving doctor's ID to several thousands of doctors and many more healthcare providers, giving IDs to hundreds and thousands of health facilities, and linking these IDs with the electronic medical records, which are residing in not only in hospitals and labs and diagnostic centers, but also in various programs, various public health programs, various non-public health programs where things like growth monitoring and vaccination, all those kind of electronic medical records reside. And most of them are residing in silos. So linking all of them is a huge vision. So of course, thinking big was not a problem. Now to implement that, from that vision to strategy to implementation plan to boots on the ground, I think we have to plan all of that. So we are starting small. Actually, India is a huge country, but we've taken only 6 union territories, which account for about 1% of India's population, and we're starting there. And we have actually put in place the basic building blocks of the mission. And I think so far the experience has been excellent, great, and we are very delighted with the way it has been rolled out. But we want to not take too long before scaling up to the whole nation. And already, I think there is a lot of impatience. In last week, the chief minister of Tamil Nadu, which is a fairly large state in the south of India, wrote to our health minister asking that they should be included in why they are ready for a pilot. UP, Uttar Pradesh, you know Uttar Pradesh very well. You work there. The Chief Minister Yogi has written a letter that why not us? Similarly, Tripura from Northeast has written that why not us? So we are hoping that once we learn a little bit more in the next 1 month or so, we want to expand to some other states, maybe not the whole India. But within 6 months, we've been told that be ready for a nationwide scale up in 6 months' time. So starting with 6 UTs and going up to 36 states and UTs, and where actually a lot of states, while some states are very keen to join, I'm sure given the federal structure of the country, we'll have to do some sales person job in other states where they may not be keen to join. Mm-hmm. And already some states have shown some reluctance that they think that it's being thrust from the top, because as you know that health is a state subject in our constitution, and so state authorities have to decide about whether they want to have this mission or not. But hopefully that wouldn't be a problem. So scaling fast is something that our Prime Minister is keen to do, and we'll be doing that soon.
Yeah, that's impressive. And good to have the demand to scale quick as well. I'm sure you don't need the pressure. But scale is not just geographic, it is, but it's also about adding more partners and more services. So I was wondering, how do you engage the private sector and maybe other partners in this scaling up?
Well, David, you're absolutely right. Private sector is the key. As you know that 70% of services in India, health services in India, are provided by the private sector. A lot of innovation takes place in the private sector. Therefore, we have been very closely collaborating and discussing and consulting with the private sector. And while we've created all these building blocks of the mission, we've also created a sandbox. And for non-technical people, this sandbox is an experimental site where these applications, private sector innovations, they can apply and they can come and they can try to connect, or they can try to see if their systems can work with NDHM, with the building blocks of the mission that we've created. And once they've tested out their applications and connections, they can apply, and we can give them a production key where they can integrate their applications with NDHM. Just to break it down and explain it in a more layperson's term, for example, each hospital has a health management information system, and they are most of these HMISs are private sector softwares. So these health management information systems, of course, have a registration system. They also create records, electronic medical records, and and also they have doctors' names and doctors' references. Therefore, and we have built those building blocks which are individual IDs or IDs for every individual and for IDs for every doctor. And if they want to link that health management information system with NDHM, they would need to have appropriate APIs and interoperable standards so that they can link with us. So for trying out whether that software has appropriate APIs to linking with our building blocks, they can use this sandbox environment. And once they have refined and honed their APIs, which link with our system, they can show us that it works. And after we are convinced that this is fine from security perspective, from interoperability perspective, and from some other checklists we have, we'll give them the production key and they can integrate with the system. So, so we opened the sandbox about 2 months ago, and we have received more than 300 applications. And out of these 300 applications, we have reviewed and given access to sandbox to about 250 of these private sector players, and they have now they're working on the sandbox. And so they're working on sandbox, and hopefully they will be applying for integration, and that's going to happen soon. In addition to these softwares and these private sector players, we've been discussing the whole structure with, say, insurance companies and how they want to be part of it. Similarly, hospitals, because in India, in some ways, hospitals are over-regulated. And what happens is that we've done some analysis. We have seen that each hospital needs about 60, more than 60, about 67 different certifications or approvals. And they have to apply to all these 67 agencies separately using different forms. So now, if they're part of NDHM, and we've been talking to all these certification agencies, that can you accept these applications through our system, through our mission, through these building blocks, and using a standard format so that the hospitals don't have to give in 67 different applications. And we've been trying to harmonize and rationalize that for them. Similarly, right now, hospitals have to, if there are about 6 or 7 or 10 insurance agencies they deal with, for their claim submission, they have to use different forms, mostly through paper-based forms, and it takes long time. They can't really follow up. They can't monitor where the forms are stuck. So we are thinking of having an e-claims platform that can be used by all insurance agencies, all government insurance agencies, including PMJ, and hospitals don't have to provide or seek their claims in different forms. So, so we've been working with hospitals so that they can see the benefit of being part of this mission. The participation in this mission is voluntary, and we are trying to show to all stakeholders that if they're part of this, they will benefit more than anyone else.
Thanks. That's really helpful to see as you describe this. The range of the scope of stakeholders and uses of the different kinds of data. Really from hospital management to claims to I think individual and providers, case management, and I think also there's direct for consumers as well, or for customers. This sandbox idea is brilliant, and maybe this is something that more of us should learn from, including us at Hopkins, I might say. Now, you alluded to this federated system. Now, federal systems, they tend to be messy. They need continual negotiation and adaptation. But I think a really interesting and elegant design feature of the NDHM is how it establishes this federated national health information architecture. And you're linking across public-private systems, state, national, different healthcare systems, different information systems. Can you tell us a bit more about how that works, how it's going to be evolved? And we've had a question particularly about what are the main concerns you're hearing from the states?
If you have a chance, and it's for everyone, you should have a look at the National Digital Health Blueprint, I think, which is a very well done document. It's a short document and very elegantly presented. And it identifies the roles at different level and what is the role at the local level, state level, and central level. At the central level, we have the role of just keeping data related to registries. So all the individual health IDs for the doctors and healthcare providers, IDs for healthcare facilities and information. And that is all that is going to be having at the central level. All the data about the medical records, electronic medical records, will be at the local level, at the hospitals or the labs where it is generated, or close to those places if they are hiring some data fiduciaries where they want to keep that data. And it will be their responsibility to keep that data safely and securely and share it based on express and open and clear consent of the individual. And then state level has the responsibility of keeping electronic health record, which is anonymized and at a macro level, and providing storage for keeping those records. So at three levels, the roles and responsibility and what kind of data should reside are clearly defined in the blueprint. And so now, since it's a federal structure, and you asked question that what kind of concerns states are expressing, the states which are quite advanced in digital health, they are actually very keen to come on board, and they want to link up with National Digital Health Mission as soon as possible. Like I gave example of Tamil Nadu and Tripura and many other southern states. They're extremely keen. Other states are concerned about the expenditure which will be involved, and they're also concerned about the problem or the potential problem of privacy and security, and how would they deal with the security breach if that happens. And of course, we have taken a lot of effort to ensure that we can support states in ensuring strong checks and balances against this, but still some states are concerned about that too.
Great, that's helpful. We also have a question, related to the policy use of the data from NDHM. Let me ask you more specifically, what is the role of the NDHM in promoting preventive healthcare? We hear a lot that you can see about efficiency in healthcare management and claims, but how do you promote preventive healthcare through NDHM?
Yeah. This is where probably NDHM will be playing a major role by recording all the inputs which are provided for preventive health. For example, all the immunization records. What happens is that our kids get immunized and we forget about it. And 5 years later, when we go to the school for admissions, we asked for immunization record, and then we have to scurry around and see, look for our old files, and sometimes go back to the hospital to get a copy of those immunization records. Here with NDHM, we are saying that all your health records from the birth to your from womb to tomb should be there, linked to individual IDs, and in a secure way. You can keep it with you on your mobile phone, or keep you in a DigiLocker, or many other services which are actually coming up securely. And so whenever you need them, you can bring them. And not only preventive health services being provided by the health sector, we are planning to have the electronic medical records being generated by other departments. For example, in India, Women and Child Development Department is involved in growth monitoring. And those records of growth monitoring will be useful for individuals, but also for researchers, that does growth monitoring lead to, say, better health outcomes later in life. So we are working with the Women and Child Development Ministry to see how those records could also be linked to in health ID, so that those are also captured. Therefore, for preventive health, data at the national level and at state level is also important to put effective policies in place. And NDHM will be able to tell us in a more effective way what kind of disease prevalence is there in which area, and what kind of interventions are being done, and how effective they are. So that will also help in terms of improving the efficacy and effectiveness of our interventions. Therefore, in terms of preventive health, in terms of recording what has been provided, in terms of ensuring better evidence-based policy making and more effective program implementation, I think this mission is going to help in a big way.
That's great. There's another big important policy concern that's close to our hearts, and that's around health equity. Of course, the national health policy focuses on universal health coverage, but often digital solutions are seen as difficult in terms of access for the most marginalized and disadvantaged communities for a number of reasons, whether the type of provider they go to or their access to technologies, which admittedly in India, digital technologies are a little more accessible. But how do you see the NDHM being able to improve healthcare for the most marginalized and vulnerable populations?
Well, that's an excellent question. And that's one thing that really concerns us, how to ensure that this mission does not deepen this digital divide, or does not further increase these inequities. And you're right that, of course, in India, the penetration of internet and penetration of mobile phones is larger than in many other countries, but still we have large population who don't have smartphones. They don't even have cell phones, or they don't have any phones. So how to reach them with the NDHM? We are creating offline modules which can be used. We are creating modules which can be used through ASHA workers, because ASHA workers are going to be having tablets that they can use for people who don't have access to internet themselves. And we are thinking of other solutions where people can phone in and get their information. But again, our thinking on these lines is fully not formed up yet, because we also have to think about security and privacy issues. Once this control goes out of their hands and it's being managed by someone else, then the security issues or privacy issues become slightly more prominent. So our thinking, the reason that we had taken this EUTs, Union Territories, was also because three of them, Andaman and Nicobar, Lakshadweep, and Ladakh, have large areas which doesn't have internet connectivity. So we wanted to test out how this mission can serve people in these areas which are not connected. So we will be looking at some solutions, and I think here the role of organization like yours comes in handy if you have any ideas about how we can address this problem of equity. That will be really great, David.
I like that. It's a huge problem, and I think that maybe we need to get into another sandbox to innovate and try some of those innovations to reaching those that are most marginalized. But it does raise the question about learning. As you said, you're 2 months into the rollout. What have you learned so far about how well the program is working? I know enrollment is voluntary. Can you tell us a little bit about how implementation is working and what you're learning in its early stages?
Well, huge amount of learning, both at the personal level, because I didn't know many of these things 3 months ago, but in terms of this mission, how we are going to be rolling it out. One, first of all, I think there is a lot of enthusiasm in these 6 places that we are working. We've done close to about 200,000 people have signed up and they've taken health IDs. Of course, that's not a big number for a country like India, even for these UTs. But we have to be also careful that unless the IDs are linked with electronic medical records, they will not see the benefit of these IDs. And we are not linking it right now because our policy for privacy and security is not finalized. It is still in draft form, and therefore, while we are building those building blocks, and these building blocks, when we launched them, there were some glitches which have been now resolved, and they've been tested out. So they're very robust and mature building blocks, and they can now go to scale. We have that capacity. Now, change management, especially at the hospital level, at even the smaller hospitals, or even at big hospitals, is a huge issue. And what we've seen is that one of the best hospitals in this region, in Chandigarh, they don't have electronic medical records. We are right now focusing on 4 records. These are discharge reports, prescriptions, OT and OPD notes, and diagnostic reports. So diagnostic reports are in most cases digitized, but prescriptions are rarely digitized, not even in best hospitals. And asking doctors and medical professionals to move towards digital prescriptions will be a challenge that we can see already. And this change management will. Yesterday, we had a long discussion about what kind of incentives we can put in place, what kind of disincentives we can put in place to move doctors and hospitals towards digital records. And that will take some time. In India, probably we'll have to learn from other countries how they achieve this. Also, in terms of capacity and motivation of the health system, and that also will require a lot of work. Other thing that we have learned is that whenever a new thing comes, there's a lot of apprehension about the intention and how this is going to affect their work. And in some cases, their apprehensions are actually right, because once things become digital, there will be more accountability, and doctors will have to keep record of what they prescribe, on what basis they prescribe some antibiotics, and they can be taken to task later on. So there is some resistance among some stakeholders that we've seen. But again, that will be a challenge as we go to scale and go to much like a to larger populations.
Yeah, that's fascinating. It's not just that this is a technological introduction. This is really a big behavior change and organizational change, social change that's required, as well as changes in power dynamics as well. You suggested that you have a lot to learn from other countries. It seems to me that many other countries are going to need to learn from what India is doing, and particularly how you're learning, which I think is fascinating. Let me turn a little bit more personally, I guess, because I'm just amazed that as CEO of the National Health Authority, you're juggling like two of the most ambitious health reform programs anywhere, and you're doing both, and yet you're still awake and obviously functioning really well. Tell us a bit about how you juggle these responsibilities, how these two jobs relate to each other, and maybe how you find some sleep.
Well, David, actually, both these missions are closely linked in some ways. And that was actually one reason why our Prime Minister decided to ask us to do National Digital Health Mission. Just as a background, you know, our authority was established to implement Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And NDHM, this National Digital Health Mission, was not in our mandate. And it's a huge mission. And the reason that they gave it to us, because they realized that we have done a lot of work on digital health already. Because in PMJ, Ayushman Bharat, we have IT solution end to end, from from identification of beneficiary, the admission of beneficiary, and then we track the whole record, whole admission, the whole process of treatment, and to discharge of the beneficiary, and the payment from the claim and the payment from the bank, from the payer. All that is paperless, and so we are dealing with the 50 crore, more than 500 million people. And so we are creating ID for 500 million people, and we are dealing with their health records. Of course, only curative health records, not all other health records, but in a way we are dealing with the electronic medical health record of 500 million people. And we are dealing with the payment structure. We are dealing with we have more than 23,000 impaneled hospitals, and we have record for those hospitals. Therefore, expanding it from 500 million to 1.3 billion people was easy for us. And that's why, and a lot of people in the country had confidence in the ability and our proven track record of implementing a huge IT project. And one thing that we are, of course, in PMJ, we have to really still go very far. But one thing that we are really proud of is a very strong IT backbone. Our IT structure, our IT system has not been down for even one day. We've been, from the day one, we've been providing services. Our dashboard is live and gives us up-to-date information, and we can check and track each and every treatment that is being given under our scheme. So that linkage with NDHM is the reason why NDHM came to us. So we had some capacity. We had people who had worked on these kind of IT solutions. We had those skill sets. And so we could leverage those to create this National Digital Health Mission, and creating a new agency and staffing and getting the skills probably would have taken a couple of years for the government to provide momentum to this mission. And many people actually say that what we've done in 2 months' time probably would have not been possible by any other organization, simply because they would have to create and get all those skills. So there is a lot of overlap between what we do in PMJ and what we are planning to do in NDHM, and that helps. And so we actually have my 50% staff is working actually on both these missions, and of course they were working full time earlier, so now they have to work overtime. And when NDHM came to us, actually my staff came and they say, can we keep some beds in the corner so that we can spend the night if we are late here? And of course, but they were serious about it. I said, no one is sleeping in the office, and we can live with some slippages here and there, but everyone has to balance their work and life. So of course we are stretched, and slowly we are getting some more people, but this has not been easy, but we are proud of what we've done in 2 months.
Well, indeed, congratulations on that. I have a few questions from the audience that I want to put forward to you.
Sure.
There's a number about the private sector and involvement, and so I guess one question is what is the vision for the private sector engagement? Are there particular gaps that can be filled, and maybe more specifically, do you already have private hospitals and labs involved in the pilot studies?
Absolutely. Like I was saying that in our consultations at the time of preparing the blueprint or preparing for the mission, the biggest consultation that we had was with the hospital networks, with the doctors associations, with the private sector startups who are involved in the health sector, with the software makers and private insurance companies. And we are working with some large hospital chains and seeing how they will integrate with the mission. We had a big meeting with all the major labs, and we are looking at how their lab management information system can link up with the mission and our building blocks. We had a meeting with all the major insurance companies and how they would like to link up with the mission. Similarly, with the doctors, we had that meeting. Of course, doctors had concerns about how this is going to impact their life, but they don't have any problem. They'll be part of the mission anyway, because we are going to be providing them IDs. And Peter, you mentioned that this mission is voluntary and it's not compulsory. But I have a feeling, and if I have to put my money on this, even though it's a voluntary thing, everyone who's associated with the sector will like to be part of it. It is something like having a cell phone. Having a cell phone is not compulsory; it's voluntary. But almost everyone keeps one because they see the benefit of having a cell phone, right? So we are hoping that everyone, individuals, healthcare providers, health facilities, all of them would want to join this mission and be part of this mission, because they would see the benefits, because this is going to improve their effectiveness. It is going to make their life easier. It is going to cut cost, and it will going to improve transparency.
Oh, absolutely. And I can see that the benefits, particularly if getting paid from insurance scheme requires being part of the scheme, that would be a huge benefit as well. There's some other questions also about the manpower or the health workforce in data science. How are you getting these people on board? And then more specifically, one of the audiences says, public digital transformation is hampered by government institutional structures that impede recruitment and retention of best-in-class digital talent because you're competing with the private sector. How are you overcoming some of these workforce issues and recruitment issues?
You know, it's very strange that you say this, because we are already seeing that that problem. We've been working with a group of consultants that we hired, and about 20 of them. And our best ones, it's so difficult to keep them right now because since the time our mission has come on board, their demand has gone up because people want to have people like those because they see when the mission will grow, many of those companies will need skills the exact skills that we are looking for. So we've lost 3 people to the private sector because private sector saw them and they said, "Nah, these are the kind of guys we need for future growth," and they've hired them by giving them, I think, twice or 3 times salaries. And of course, uh, keeping, attracting, and retaining good staff in the government is always a challenge. But what I found was that in PM Jai Ayushman Bharat, we didn't have that problem because a lot of people wanted to be part of this mission, which is so transformative. And they believed in the mission and they believed in what we were doing. And they were willing to work with us on government salaries because they liked the job. And I'm hoping that the same thing will happen with the NDHM because it's so transformative. It'll going to change lives of so many people, and actually it'll change the sector in a huge way that many people who want to be part of this probably will not care about money or because the experience of working this will be invaluable. And frankly, myself, uh, 2 years ago, 3 years ago, I was earning about 20 times what I'm earning now. But if I have to do it all over again, I'll do this the same thing. I'll take this job because this job, in terms of your ability to make change, in terms of your ability to do things which will impact, have a positive influence over the lives of millions of people, I think there's no other job like this. So I think we will still find, I think, core set of people who will not mind being paid in government salaries for doing a job like this.
That's a remarkable testimony and vision and really impressive. I think that we feel similarly at Hopkins as well for the mission.
The dean is listening.
So there are a couple other questions about governance of this, and particularly if you could expand a bit about the legal framework and how it's differentiated at different levels, and particularly federal versus state and private sector, but also about how data is managed and some of the protections around that and its uses.
Yeah, I think, I was telling you about our data privacy and security policy and 7,000 comments that we've received. Some of the comments are exactly about this, that, why is this work being done by Government of India when health is a state subject? Second, since we don't have any uh, act which is approved or has gone through the process of parliament. Parliament has not put any act for protection of personal data. Why has this mission come? Why didn't it wait for an act which ensures privacy and protection of personal data. Now, the issue is that there is a bill called Personal Data Protection Bill (PDP), which is in the Parliament, and hopefully it will come up for consideration in 2 months' time. And so our policy is actually based on this bill. And this bill actually has gone through several layers of discussions, including discussions in Parliament through a parliamentary committee. And so we've we've taken all the elements of this bill in our policy. But in addition to this, we have two other policies which actually have given us some support. One is IT Act, uh, which have provisions of what kind of privacy, what kind of security should be there in digital data, IT data. And also second is Aadhaar Act, and which has provisions about again security and privacy of data linked to Aadhaar and Aadhaar itself. And then we have numerous Supreme Court judgments on this issue, which are also which guide us. So based on this, we believe that the policy that we have put in place, the draft policy that we have put in place, is quite robust, and I dare say one of the and also is based on a lot of international best practices, and we've incorporated many of the ISO regulations in this policy. So while it is correct that it would have been good to have a parliamentary act that could have guided us, but even in the absence of parliamentary act, we believe that there are several statutes which are there already in place, which can guide us. And as and when there is a parliamentary act, we can, if we still find there's some gaps in our policy, we can do that. Second issue about why we are doing it, why the states are not doing it. See, again, state center still has a role to play in terms of health. We provide 60% of resources for the health sector from Government of India. And for COVID, much of the resources have been coming from Government of India. And in terms of coordination of communicable diseases, I think there is a big role to play by the center. And similarly, for interoperability, in terms of ensuring that data doesn't go into different silos in state level, I think those are like a public good in terms of ensuring that the standards are followed, which make the flow of data from provider to provider, from state to state easier and interoperable. That is the role of the center. Therefore, having this coordinating role, I think, is well within the responsibility given to the center, even in this federated structure.
Thank you. Now, we only have a couple of minutes left, but I did want to ask you maybe a big question. You've had an amazing career, and it would be good to hear from you. What are some of the things you're most proud of, and what do you prioritize going forward? I realize I haven't left much time, but it'd be really helpful to hear your thoughts there.
Well, David, I think that's a difficult question. Maybe a difficult question for the last, but yes, I've worked in ADB for 21 years, and there are many things I did there which I still remember. I can really feel proud of. In '97, there was a crisis which was there in Asia. Then I played some role in supporting response to the crisis. In Vietnam, we started with the government this healthcare for the poor, which actually became the basis for their universal health coverage, and the government of Vietnam putting in a scheme like Ayushman Bharat later on. And in Cambodia, I did this public-private partnership through provision of services through NGOs. That was very gratifying. And then response to SARS. When SARS hit Southeast Asia, I used to be head of the health sector in ADB. That I'm hugely proud of. And then as Director General of Strategy and Policy Department in ADB, I was part of core part of the mission, which actually tripled their capital base, and that was also actually huge learning experience and very gratifying. And of course, coming back to India and doing this has been cherry on the cake. And so I've had a very blessed, very I think good career so far. Can't complain, David. I'm very blessed.
Well, thank you. I feel blessed and honored to be able to talk with you today. Clearly, we have more to talk about, but thank you for your insights. I want to thank you, particularly get insights from somebody at the center of such major changes. So we have a lot more to learn, and hope we can continue to learn together about the journey of these programs, but also your personal journeys and the impacts you've had in many people's lives over time and place. So I just want to thank you very much, and look forward to the next time.
Great catching up again. Bye.
All right, thank you.